It's about 1.4 million children that are uninsured. And again, those children, and we have about 800,000 less this amount that would be eligible that are not enrolled.
So two-thirds of the uninsured children are eligible now and would not really be affected by this bill. Is that correct?
Except for some of the outreach components, they would be less affected, and then because along with the screening aspects, more children might get into the program.
Okay,
but
great.
It's not based on policy changes in this bill.
Okay, and based on eligibility, how would your bill affect the other one-third of the uninsured children? Would that capture all of them?
No.
Okay, now you understand that in the United States we basically have a three-tiered payment system in medicine.
Say that again.
In the United States we appear to have a three-tiered payment system in medicine. We have a private market.
Are you asking a question?
I'm getting to the question,
okay.
Sir. We have Medicare, which is at or below the market. Have you ever had trouble or complaints from people trying to get physicians for seniors?
Oh, no doubt about it. I think there are continual challenges, and it has to do with reimbursement rates.
Okay, and you're aware that Medicare has reimbursement rate issues then? And you understand,
certainly aware of that.
And you understand that CHIP and Medicaid have reimbursement rates approximately one-half of Medicare.
Yes, I do, and I know those are issues that are in a rider that I put on the appropriations bill that has gone to the Conference Committee on the Budget that is looking at the reimbursement rates for providers in CHIP and Medicaid as well as long-term care.
Yes, and you understand that the goal of your bill, I assume, is to have children in Texas have a personal physician.
That is the goal.
And so I'm trying to figure out, with the way this bill is written and what's going on in the House right now, is whether physicians are going to be able to see these children. And
yes, based on the increases in the reimbursement rates that are in House Bill 1 and Senate Bill 1.
What level do those reimbursement rates go to?
I'm not sure what the general amount was. I know there was a total of about 200 plus million that would go in to increase those rates, Dr.
Okay.
Shelton.
Now, do you understand that currently, under the current reimbursement system, if a practice of a family practice doctor or a pediatrician exceeds about 35 to 35% Medicaid and CHIPs together, then that practice is probably non-viable. Have you ever heard those numbers before?
Yeah, my father was a physician. He was an OB-GYN, and we lived in the hood, and those were his patients. So was my father-in-law. He lived in South Central L.A., and that's where his patients were. I think we pretty much understood growing up what that means.
Okay, great. And if a family practice who is not a plastic surgeon or an anesthesiologist,
oh no,
they're not.
Definitely not. I went to a great family doc here in Austin and one in Houston because of some illness, and I can just tell you they're very good. They're the best thing that you could ever find, but it's very difficult to make the same amount of money as a plastic surgeon.
I understand, and so you understand it's difficult for the family practice doctors, and when they're losing money on every patient, they really can't make it up in volume.
That's right. That's why I voted with Mr. Chisholm on his bill to decrease the cost, to make sure there was reimbursement for family docs at the rising cost of a medical education.
Now, do you understand now that about a large number of the CHIP patients actually end up in our emergency rooms? A much higher cost of care center than a
I understand that a large amount of any patient, insured or uninsured, still ends up in the emergency room.
That's right. And under the current system,
and I think that has a lot to do, quite frankly, with Saturday openings, late in the day and the evening openings, and some new emergent care. But the most important thing is for somebody to have a primary care physician.
That is correct. And so you would agree with about 3/4 of our CHIP emergency department visits under the current system are probably medically unnecessary.
I would agree that many times when anybody with any insurance uses the emergency room because they don't know whether or not it's emergency or not, that it may end up being unnecessary. And I would only add that the reason we have EMTALA is because under the reasonable person standard, it was chosen not to leave that to someone who's not trained as well as you are, Dr. Shelton.
Well, thank you. And I wanted to go to eligibility for a moment. What is the income level for someone at 300%?
Oh, they're different. It
Because
depends
you're
on family size, Dr. Shelton.
Well, let's say for a family of four, and that's usually what people
For a
talk about.
family of four, the actual 100% of poverty is $21,200 per year, and that's gross income. If it is under the regular CHIP program, that gross income, and what did you say it was again? What were you asking about?
300% poverty for a family of four.
It's probably somewhere around 49,000.
Well, I have a little bit different numbers.
And you may have a different number.
We think the 2009 federal poverty levels are 66,000 for a family of
Now,
four.
you know that under this bill, the premium is 100% paid for by the family. Nothing is paid for by the state in the buy-in program for 300 to 400% of poverty, right?
I understand, but still.
I know you're asking me the question, but I want to clarify too, that is not paid for by the state. I think when you ask the question that way, it implies that the state is paying that premium, and they are not. It's 100% buy-in plus. You have to pay for the insurance, then you have to pay a fee. So all of the costs of the state of Texas, no matter indirect or not, are paid for by the family.
But that does not change under your system, does that change the reimbursement to physicians or healthcare facilities?
It wouldn't change the reimbursement because they have to put the program together to make sure that this works. But remember, this is a new program. The only kids that can be in it are kids that have incomes have risen and they pop out of the other buy-in program. It's not open to the general public.
I understand. Now, in your bill, did you have some other special income adjusters other than just the federal poverty level?
It's called, I think it's called that thing that child support. Yeah, that one, child support. You know, when people pay for the children that are living somewhere else. Child support is adjusted gross income, is adjusted from the gross income.
Okay, will this bill prevent families, how will this bill prevent families from dropping off private insurance and going on the CHIP program?
Well, this is what's really important, and I think that it's not really clear, but we actually extend the number of months that someone is frozen out of the program to 6 months under this provision. And we actually extend the period of time that someone can get in the program, that they can't get in the program, to 90 days under this bill, and that's for families under 200% of poverty, because it was important that crowd out be dealt with so that we're not pulling from the federal government. Actually, and what's really important, I looked up this guy, got some help on this, that you know, he's kind of like the guru of crowd out. And basically he said that if you do 6 months in 90 days, then that takes care of all the crowd out that you can possibly take care of, except not doing the program.
But there would be no penalty or enforcement or looking for people who were changing from private insurance to this program?
There never has been. There never has been that. Basically, everybody has to go through an eligibility determination, Mr. Shelton, and everybody has to go through that same process. And if that person is not eligible for the program, then they can't get in. The deal is that that individual family has to be uninsured in order to be in the program, and have been uninsured for 6 months prior. And that's what's the important part. And that is what deals with the crowd out provisions.
Okay. Now you're aware
deals with crowd out.
You're aware that rural Texas has a lot of trouble recruiting and retaining physicians in their
Yes,
community.
and that's why I'm the House sponsor of Senate Bill 1500 by Senator Duncan that actually allows hospitals to hire physicians to deal with the recruitment of physicians into rural Texas. And I'm very proud to be the sponsor of that bill.
And you're familiar with the Fruh settlement, I assume?
I'm very familiar with the Fruh settlement. Wait, hold up. Let me answer the question. I'm familiar with the Fruh settlement because I worked on the first time with the Fruh settlement to put the money in to make sure that we were in compliance and that our rates under dental and primary care, that we were in compliance with those rates. In 2003, there was a $10 billion shortfall, and in that $10 billion shortfall, the rates were cut. When those rates were cut, some of them were put back in the last session of the legislature, and some were put back in 2005. Some will be increased in this budget, and you can ask Mr. Pitts about that. But in terms of whether or not the Fruh settlement is what's supposed to do is raise those rates for screens and for dental checkups.